This is reducing the health and economic burden of chronic disease. So if you didn't mean to be here for this, that's fine if you want to leave. But it's going to be really interesting. We have a really diverse panel here, and we have to cover all of chronic disease, both health and economic impact globally. So we're going to get into some big problems, but then move towards some concrete solutions. We have people from academia, from industry, and from advocacy, and we're going to see how to utilize everything, bring everyone together to see what can be done about the chronic diseases, which are most of the spending in the healthcare system and an ever-growing percentage of it. So to briefly introduce the panelists, down here at the end is Bill Dietz. He's the chair of the Global Center for Prevention and Wellness at the Milken Institute School of Public Health at George Washington University. Ellen Siegel is chair and founder of Friends of Cancer Research. Tom Beauregard is executive vice president and chief innovation officer at United Health Group. Frida Lewis Hall is executive vice president and chief medical officer at Pfizer. And Stefano Bertozzi is dean of the School of Public Health at UC Berkeley. So when we talk about chronic disease, I think the word obesity comes up probably more than any other word. This is an area of expertise for Dr. Dietz, and I was hoping he could start us off with sort of the scope of how that is shaping our approaches to chronic disease and where that leaves us as an understanding of what are the factors that go into chronic disease that we are talking about overcoming here.
Great, Jim, thanks, and good afternoon. I should add to my introduction that I can bring to this the government perspective, because for 15 years I was the director of the Division of Nutrition, Physical Activity, and Obesity at the CDC. And we really focused on obesity there as a national problem. And to give you an idea of the scope of this problem today, about 9% of 2 to 5-year-olds have obesity. About 17% of 6 to 11-year-olds have obesity. And about 36% of 20 to 39-year-olds have obesity. There are very significant disparities associated with obesity. African American women, Mexican American women tend to have a higher prevalence than does the Caucasian population. And although it's widely assumed that obesity is associated with poverty, the only group for whom that's true are white women. The associations of obesity in African Americans and Mexican Americans are flat across ethnic groups, across those two populations, across poverty levels. I've become real interested recently in the risk posed by the development of obesity in 20 to 39-year-olds. About 20% of that group gains 20 kilos, or almost 45 pounds, in that period. And we know virtually nothing about why that is or who those people are. We don't know even the most fundamental of demographics, except that there's a greater risk for excessive weight gain in African American women, although it's not exclusive to them. The other characteristic about obesity is that every system in the body is affected by obesity. You probably know the main consequences of obesity, like cardiovascular disease or like type 2 diabetes, which is deeply associated with obesity. But you may not know that about 20% of cancers in women and 16% of cancers in men are associated with obesity. So this is a very widespread problem, one with substantial consequences, and one which is also very costly. We published a paper when I was still at CDC that suggested that about 10% of national healthcare costs were associated with obesity. And since that paper was published, more recent estimates from the Milken Institute suggest that it may be closer to 12 to 13% of total medical costs. And that's in part because of these associated diseases. This is not a problem that we're going to treat our way out of. I think during the course of this panel, we'll talk about scalable solutions. We'll talk about the effects of cancer. And cancer, I should add that not only is obesity a risk factor for cancer, but after the diagnosis of cancer, it's a risk factor for recurrence. So it's a pervasive problem. And
Dr. Bertozzi, I know that you have a global perspective on this being not just a U.S. problem. How is obesity shaping chronic disease globally?
If you're going to set me up like that, I'm going to have to show my one slide.
You have a slide?
Can somebody show me slide number 1? This is looking at what's changed from 1980 to 2013 in the prevalence of overweight and obesity around the world. And it's pretty astonishing. Before moving back to the US, I lived for 11 years in Mexico. And in Mexico, diabetes is now the #1 cause of morbidity and mortality. I was told recently, I assume it's true, but I can't give you the citation, that in Los Angeles, fatty liver is already the #1 cause of liver transplantation. And Bill, you mentioned that there are racial and ethnic correlates. And just like everything else in the healthcare system, I think we always have to ask ourselves, when are those racial and ethnic correlates of race or correlates of racism? And in this case, it's a complicated mix of things. So I think that the Latino population is genetically predisposed to fatty liver when associated with sugar intake and obesity. And African Americans are relatively protected. I don't think that's a question of racism. I think that's actually genetic. But that tends to be the minority of those kinds of associations. But we're going to get, what I'd like to do is come back a little bit to some of the solutions that we're going to talk about today. Domestically, what does that mean globally? And which of the things that we talk about here are scalable in this country as opposed to very useful in pilot projects, and which of them are scalable globally? So I'll leave you with that picture, and maybe we can talk a little bit about some of the responses domestically.
Yeah, maybe I can jump in quickly on the scale issue, because it's so critical, right? I mean, we recognize that sort of obesity is at the base of so many chronic conditions. But one of the things that we've been focused on for roughly 10 years now is a program called the Diabetes Prevention Program, which is, in essence, it's an evidence-based weight loss program. But the data from all of the studies would suggest that if someone who's pre-diabetic loses 5% of their body weight, then they reduce their risk of converting to full-blown diabetes by 50%. So it's kind of a magical intervention. But the key is, how do you make that scalable? Because it's been around for 20 plus years. And so we've been sort of on this mission in public and private partnership to try to drive that program forward. And we tried a lot of different things, and we had a lot of learnings, but just a sort of a quick tour of this is we did our own research, as we often do, just to confirm the data. But then we did a deal with the Y nationally to do group models, and that's the way typically the DPP has been delivered. And what we found was we were able to replicate the evidence, the 5% and the 50%, but we had a really hard time getting people screened, engaging people, and we had a really hard time keeping people in for 13 sessions. So we saw massive drop-offs because it's group, you have to be in person. The Y is in a lot of places, but it's not necessarily, you can't nationally scale through the Y. So then we turned to a virtual model, and we actually did this in combination with NBC and created a virtual model that was entertaining, it was engaging, but it was basically like a reality program called Project Not Me. And what was fascinating about that is we were able to replicate the results, get the same results that you get in the group model. And it was delivered through on demand, so people could watch it when they wanted in the trial. And that's now evolved to a completely virtual solution that we offer to all of our insured members. And that, to me, we've got over 300,000 people enrolled in that. We're not calling it a diabetes prevention program. It's called Real Appeal. And it's basically, from a consumer perspective, it's free weight loss. It's a program that is engaging, it's easy, it has celebrities, but the underlying model is the diabetes prevention program. And the other thing that we abandoned, and I think this was an important lesson, was screening. We didn't need to sort of incur the expense and the time to identify someone as pre-diabetic. In fact, we don't care. If you want to lose 10 pounds in this program or 5 pounds in this program? So it's, to me, it's sort of the lessons are, as you try to figure out how to move evidence-based programs to scale, you need to make them really simple. You need to make them cost-effective, meaning you can move quickly and not have to set up sort of physical structure for it. You need to make them entertaining, and again, they have to be completely free.
So you're almost functioning like or competing with a lot of messages in the media about weight loss and how to break through this very crowded marketplace.
That's it, and a lot of it is language that you use. I mean, we joke, but when oftentimes you tell someone they're pre-diabetic, they say that's great.
I'm not diabetic
and
yet.
off they go, off they go. But
Yeah.
there's just a different way to approach this that's more cost-effective and scalable.
So can I?
Yeah, please.
I want to switch and do just a little bit of context, if that's okay, from
The more context,
a
the
different
better.
perspective. So if you kind of look at this from a 30-year run, we've just started to really pay attention to obesity and its causes, its effects, and what to do about it. I know that there's been a core of people who have been focused on it for a while, but to call it a crisis and really have a sense of urgency around it, we're just now kind of getting into that. If you could pull slide 2 for me. So my context for urgency is this slide. This is my graduation in 1976, undergraduate from Johns Hopkins. And you see my dad, who was there with the tie on, and my mother in the pink, and my uncle, who was sitting in the wheelchair. And this has kind of been my framework for my medical career. My uncle was struck by polio in 1925, a paraplegic as the result. And I and my contemporaries, of course, are not facing a polio epidemics as my dad and their contemporaries were. But we shifted into something different. The next summer in this picture, my mother died of a stroke suddenly. And my dad today is 98 years old and relatively healthy, perhaps at the magical hand of fried bologna sandwiches. I'm not quite sure. But the idea is infectious disease has taken a bit of a backseat, at least in the US, not all over. Sudden death amongst high-risk individuals. It continues to take an enormous toll. And then, inexplicably, there are people who live quite long and healthy lives, although the relative truth is that we're not really living longer, we're just taking longer to die. But this is, for me, a context. And then just one more, if you will. The next slide is 3. And the reason I said 33 years is because this is the slide that makes me cry. This is the context for the Framingham study and the results that it provided. Arguably one of the most amazing studies ever conducted in the medical community. When Framingham started to share data was in the 1950s. My mother died suddenly of a stroke in 1977, nearly 30 years later. Much of the information that was available in the Framingham study about risk, about prevention, about interventions, and many of the tools actually existed long before my mother died. So my question for us is whether or not we can begin to shrink these 30-year windows to begin to use what we have available to us to change the face of chronic illnesses. And I think this is the code that we need to crack.
Yep.
And I think I wanted to throw to Ellen because we're talking, I wanted to focus a lot on obesity, which has its hand in so much of chronic disease, but we also are thinking, Ellen is a cancer advocate, cancer cure advocate, and so how are we thinking about that as a chronic disease now, and how, are there lessons from your work that could inform ways that we bridge that sort of gap, close that really long lag period between
The
insight
answer
and
is for sure,
implementation?
but I'm feeling incredibly guilty because there was a croissant filled with cheese that was served as a snack before, and I'm thinking maybe I shouldn't have done that. So the idea of cancer as a chronic disease and as a preventable disease is interesting and new. We've always known that many cancers are preventable. So, and obesity is a factor. So we certainly know about behavior. We know about lung cancer. We know about obesity with breast cancer and colon cancer. We know about alcohol. We know about sun. And yet, that behavior continues. It's really pretty. We've changed a lot of the. We've been pretty successful with smoking, but not completely successful. We don't screen people early enough that are at risk, and we don't even actually know who's at risk. The obesity is a huge issue, and cancer as a chronic disease is an issue because when we started treating people with cancer, we treated them so they could live, and we didn't really care a lot about side effects. We knew that they were toxic, we knew that they would be sick, but we were saving lives. And now we have almost 13 million cancer survivors, and as a result, they're living, and that's the good news. But as a result of some of their treatments, they have a lot of conditions, neuropathy, hypertension, cardiovascular disease, lots of toxicities because of the treatments. So we're trying to learn how to cope with that. The objective is still to keep them alive, but the other objective is if we can't keep them alive with quality of life, that's a huge issue in patient-reported outcomes, and we're only beginning to learn about that. So there are huge risk factors in cancer. Some of them are preventable, and I guess the bottom line of it is we're making a lot of progress, but in other ways we are absolutely not. We still see people refusing to get their HPV vaccine, to be screened for colon cancer, and still people who are smoking and people who are sitting, even in beautiful LA, sitting and soaking up the sun. So a lot of work to do.
Yeah. So, but there's maybe not a single like lesson of how that lag didn't, something where it didn't take so long for research to be implemented.
I think that in some areas we are screening. Men are getting PSA prostate cancer screening. We can debate how useful and how and whether in fact that is we're over screening and over treating. So people are starting to get their colonoscopies, not so much. Screening for lung cancer, not so successful, even though people who are at high risk, who have been smokers for a very long time. We have the spiral CT. I don't know that that's adapted to practice a lot because we can catch people early and then we can have interventions that really work. So there's a huge amount of progress and knowledge, but it still comes down to the fact when people get a diagnosis, they say, how did this happen to me? And in many ways, we don't know. And blood cancers, brain cancers, and other things we know, it's totally preventable.
Yeah. Is that a key to talk a little bit about prevention and how we can use public health programs to maybe take on things at a broad level?
Right. So one of the things that I didn't say was that I think we're making progress in the control of obesity, particularly in children. So in 2 to 5-year-olds, the prevalence has decreased, and it's decreased both in the general population as well as in children involved in WIC, who are a particularly vulnerable population. The prevalence in 6 to 11-year-olds has been flat for 10 years. The prevalence in women is continuing to increase. In men, it's maybe flattening. And so it begs the question of why. And what's happened at the population level is that the consumption of sugar drinks, the consumption of fast food, and the consumption of pizza have decreased. Each of those foods has been rationally, if you will, associated with obesity. In other words, that we can't point directly to those, but we know that the consumption of pizza, for example, by a teenager, on average consumes 600 calories a day, which is 250 calories in excess of what they would ordinarily consume. And people who consume sugar drinks don't compensate for the drink. And the statistics on the calories from sugar drinks are astounding. So if we just look at adolescent boys and young men, over 500 calories a day of sodas are consumed by the top 25% of the population. So that poses a target. And our focus at the CDC became, how do we begin to change the environment that promotes obesity, on both the environment that drives obesity as well as inhibits physical activity. So we began by thinking about baby-friendly hospitals because we think breastfeeding is protective against early childhood obesity. Baby-friendly hospitals are hospitals that have in place multiple strategies to promote breastfeeding. And it's been shown that both the initiation and duration of breastfeeding is increased by baby-friendly hospitals. So that was one. Early care and education centers, a captive audience. Children are particularly responsive to changes in the physical activity and nutrition guidelines for early care and education are an important strategy. The Obama administration was instrumental in changing school feeding programs in a very positive way. And I don't think without Michelle Obama talking about obesity that we would have had the same, that it would have had the same visibility as we have today. And the Let's Move initiative began with schools and began with parks and recreation facilities and salad bars in schools and physical activity programs, all of which were policy related. And the other substantial change was, and full disclosure, I'm a board member of the Partnership for a Healthier America, which was the outreaching or outfacing organization that began to implement the Let's Move initiatives by establishing voluntary commitments with companies that were providing products to children. So one of the things that, one of the negotiations with childcare companies to provide better nutrition, to restrict fatty foods, to eliminate juices, and to provide more physical activity as an indication of some of the kind of environmental changes that I think have been necessary and have contributed to the decline in childhood obesity.
So how do you scale these programs? Because anecdotally, I walk around and I see people more obese than ever, drinking these soda drinks, drinking these I mean, how do we scale that? How do we really get that so it actually matters?
Well,
into the
a tax. A tax will do it. Because, and not a sales tax, but an excise tax. And I'll let Peter talk about the Mexico tax, but I think that the tax that it's now been in place in 6 or 8 cities in the United States. We have data from Berkeley which suggests that it's been very effective not only in reducing purchases but reducing consumption. We don't yet see an impact on obesity, but I think we can anticipate it.
But the sodas and these high caloric things,
Right.
there's just a higher cost to them, sales tax?
Yes. So, well, an excise tax increases the price on the shelf, so you see it, as opposed to a sales tax, which you don't see.
Correct.
Yeah.
Okay.
I mean, there have been several national level implementations. Mexico was a very well-known one, and Berkeley was the first one in this country. But now we've got Berkeley, San Francisco, Albany, California, Cook County, Illinois, Oakland, Philadelphia, and Boulder, Colorado. So it's happening quickly, and globally, France, Hungary, Ireland, Norway, South Africa, United Kingdom will take effect in 2018, and several islands countries as well. So in just the last couple of years, we've seen a real growth in the use of taxes to reduce the consumption of sugar-sweetened beverages. Some of them include junk food, like Mexico does. It's sort of a junk food and soda tax. But the changes in consumption in Mexico have been dramatic. A shift away from sugar-sweetened beverages to water and healthier drinks. Mexico consumes an even higher proportion of their calories through soda than the U.S. does. And it's not surprising that so much of its morbidity and mortality is related to diabetes. I think one of the mysteries, we've talked about the Framingham study and all the, I wonder why it took us so long to figure out that the relationship between fat and sugar. We spent many years telling people to eat margarine and have all the sugar they wanted, and we didn't worry about Coca-Cola. And nowadays, I think we're seeing both the addictive effects of sugar and caffeine together for kids in many ways that parallel what we did with kids and tobacco decades ago. And I think we're seeing similar responses. I'm amazed when I see the television ads. I went to Mexico last Christmas. You're sitting in the movie theater and Santa Claus is telling kids that to be a good person you drink Coca-Cola. In a country where diabetes is the #1 cause of morbidity and mortality, that's profoundly unethical. And so I think we have to address the role of the private sector in this as well.
Well, not to dwell too long on the soda tax, but I like it as an example of something that sort of ties in a lot of different areas of health and then meets with, I know that the opposition to the soda tax is generally that it would hurt the businesses, the local businesses that sell soda, the corporations that sell soda. This is bad for business. In the current political atmosphere, that is it too optimistic to think about a soda tax being a short-term realistic solution? Do we need to think?
Nationally, I think it's very unlikely. But
Well, but
that doesn't mean that there can't be huge progress at the state level.
at different state levels is where things could happen.
But it's not the only thing that we have.
But yeah, I mean, in that spirit, that sort of policy is what I mean. Yeah.
Well, I was really tapping into, because you made the comment of, if I think back, 20 years ago when we started to turn the corner on cigarette smoking and its tax, I mean, to go and buy a pack of cigarettes, you'd have to be able to drive it out of a store. I mean, they are so expensive, but we didn't really account for the addictive nature of tobacco in the
Right.
space, and you just tapped into the idea that some of this is behavioral and directly within the kind of context of personal change and habit, but some of it may be physiologic, and we haven't cracked the code on whether or not this side of the room is facing that as breaking past this versus the other side of the room. I don't think that we've been able to parse that out yet, one. And then two, I think some of the ways in which we intervene don't take into account, we were talking about obesity and body image earlier, for example, and so how you would convince one person that this is an important issue, that obesity is an important issue, and oh, by the way, we're talking about you, and I'm saying that because we actually looked at some data around people who agreed that obesity was an issue, kind of got it right as to the percentage of the U.S. and other populations that were obese. They clearly were obese by all of the parameters that we use, but they did not know that we were talking about them. So I think that the personalization of this and then translating that into action is also missing for many people, and I'm not sure if we've cracked the code on that yet either.
Is it?
Another component to this, because even if you start to crack the behavior on tobacco cessation, if they're smoking for 20, 30 years, they're still at risk. I don't know what the numbers are on obesity, but if you're 50 or 75 pounds overweight and you suddenly lose weight, are you suddenly healthy, or what about all those? That's a different issue. So we still have risk factors even when we can change behavior.
Right.
Well, and then that leads you into, we're talking a lot about sort of prevention and how to scale evidence-based programs, but then there's this other element, which is how do you help people that have a chronic condition manage, right?
Yes.
Once they actually are crossed that line, they're diabetic or whatever the condition is, and that's where I think, and we talked about this a little bit as well, but the sort of the promise of digital health, these FDA-approved devices that are available and currently not being utilized at a high enough rate, right? If you think about the way disease management works in this country, it's pretty ineffective, right? You see your specialists 2-3 times a year. There's a shortage, of a number of specialists depending on where you live. You show up with no data. People sort of don't always tell the truth, or they can't remember sort of how they're doing. And then you have companies like ours who do telephonic outreach. So the model for the actual patient is not very strong in terms of actual management, and the promise of digital health to help someone sort of on a real-time basis understand their condition and their data points and be able to reach out. And we're doing all kinds of studies in different areas, pain management, asthma, diabetes, where we're using these FDA-approved devices and doing outreach. And the strongest example I have is in the asthma category, because it's kids. And so parents sign their kids up, and they have basically a cap on their inhaler that's Bluetooth enabled, and then activity monitors, and actually able to see how often they're using the inhaler, pulmonary function, and activity, which is, that's all you need to sort of understand if you're about to have an event. And you can do outreach to the school nurse, or to the parents. And the promise of that is just amazing. And I will tell you, just on a sort of a more human level, the way people enroll in these studies, particularly when it's kids, because it's typically mom that's managing the condition. The power of these models for people that have chronic conditions is just, it's amazing. I mean, it'll really transform the way we do disease management in this country.
For somebody who's been out of the country, you guys, let me ask you guys, the two of you, a question. You come back to this country. I've worked abroad for many, many years. I come back and it seems like I go to sleep one night and I wake up in the morning and Uber and Lyft are everywhere. I mean, this just happened instantaneously, and yet we have clinics across this country that do a great job of managing these chronic conditions and clinics that do a terrible job. This heterogeneity is maintained for decades. Yeah. Why do you guys think that our systems are so bad at learning from best practice in this space? I mean, I'm thinking, Frida and Tom, that you guys are more in the thick of the why the systems don't learn from each other more effectively.
Well, I mean, I'll take a little bit of a shot at it, and I agree with you. And we were talking earlier. Amazon knows everything about me. They know what I read. They know what I watch. They, know what size I wear. They know, everything about me. I go to my doctor's office. They hand me a clipboard, and I got to write my name down. You don't even know who I am. That is so confusing to me. So, I think that a part of this is the fact that we're not connected. We're not connected to the people that we serve, and we're not connected to each other. And I think that allows us to do amazing things unto ourselves, in the little kind of lanes that we swim in, but for a whole host of reasons, including incentives not to share across, across the spectrum, that we end up locking ourselves into this pattern of repeating the same mistakes over and over again.
We have in cancer evidence-based guidelines, treatment protocols, and the variation in practice between a community practice and an academic practice and a regional practice is astounding. It's not the same. For the same cancer, you can have 3 or 4 different options depending on where you wind up.
And is this because doctors still want to see medicine as an art and they don't want to be following specific algorithms and just doing what they're told?
There's a little bit of that.
Is it simply no one informing them is a lack of?
It's very difficult these days because the explosion of data that is coming at us on genomic testing and on immunotherapy is difficult, but their variations are different. A local practice where there isn't a very specific expertise in a rare disease or rare genetic testing would likely to give you a very traditional protocol that maybe is 10, 15 years old. If you go to an academic center, they'll push a trial that they're interested in. The variations are enormous. There are guidelines, but the treatment protocols or the interpretation or the flexibility of what you're going to get for treatment for the same disease will be different in many, many different areas.
Yeah, and I would say, great intentions, but providers it's still, very, very fragmented, and these are busy people with no data. It gets back to this idea that you need aggregators that look at the clinical protocols, that can look at an individual's sort of performance on a day-to-day basis. And we can't ask docs to do that, right? But we have to have systems in place where we can reach out with that data to support the care. And that's great for the patient, it's great for the physician, it's exactly what both parties want.
Now, I don't want to sound like, I don't want to sound like all is lost, though, because I do think that we're at this pivot where we understand the power of data and data analytics to the practice of medicine. And, we've heard some people say at one point it was, I guess your point about the art, it was really kind of the individual physician practice institution that had the information and they practiced in that way. So it was clinicians using data. And now we think that it'll be data using clinicians that will be able to aggregate, analyze, become a truly learning system once we're connected in the way and can gain insights, not from the 100 patients that we have in our practice, but the 100,000 experiences that are had across the country and then ultimately around the world. I think we're like almost
But we need
there.
interoperable data. Frida, we have at the FDA, we have 200 million lives in Sentinel, but that's claims data. Then we have the CORI, 70 million. They don't talk to one another. The standards are different, how to use that data. So, and then we have a lot of hoarded data by companies and by academics that are not being shared. Standards are different, so we have
got work
great
to do.
data.
We're at
but
the portion of this panel where we talk about the importance of sharing data, which has
Correct.
probably happened at a couple other panels today. Maybe you can talk a little bit about aligning incentives in a way that is it just never going to happen so long as there is competition, or is it a matter of uniqueness of health data and privacy concerns? What's making us not be Uber and Lyft?
Yeah, no, so I think there are, from a data perspective, I think there's a lot more data sharing that's occurring, both as public aggregators. So I'll use a specific example, like with the Healthcare Cost Institute, where payers have aggregated data for research. We do a lot of our own research that we publish through Optum Labs and other entities. We give researchers access to our data in ways that historically the industry hasn't. So I think that has been there's been real breakthroughs in that in the last 5 or 6 years. I go down to the sort of the personal data level, and it's there's aggregate data, claims, and clinical for research that's clearly required, but the use of personal data, and I love the Amazon analogy, the idea that I should be able to walk into an office without checking in, and I'm there. The Amazon Go model, right? So I'm there. You're tracking my wait time. The endocrinologist has my data, from my Bluetooth-enabled device, and that's the experience that you want, because you'll get just so much better sort of consumer satisfaction, but also more importantly, better patient outcomes.
You don't think that would freak people out?
Well, there's a question, and that's a really legitimate question. It's not the health insurance company, right? That's surveying you, because that's creepy. But what it is with consent is, we'll reimburse the devices because they're FDA approved. We'll support the analysis. We'll reimburse physicians for looking at that data, right? Because there's a return for us in that, and it's also just better clinical outcomes. So I think, but I will tell you that the trial work that we're doing in this with these FDA approved devices, I talked about asthma, but when we look at work we're doing in pain management, arthritis, diabetes, the trials fill up really quickly. People want help managing their chronic conditions, and they're willing to share that data as long as they understand that you're not underwriting with it, which we're not.
We have to
I think,
also
go ahead.
value patient-reported outcomes and data that really makes a difference for patients. We have to put them on the label. We have to collect the data. We have to do it in a systematic way, because patients want treatments that will work for them, but they also want quality of life, and we haven't paid a whole lot of attention, a lot of noise about it, and now it's becoming very different and serious, and I think if we pay for it, and you pay for it, and reimburse for that, and it's on a label, people will start to care about that and behave differently.
So I think obesity is in a different category. We know that there are 150 genes associated with obesity, over 150. We're at the cusp of beginning to identify medications that will work. But we've been looking at the level of understanding of providers, physicians primarily, in addressing a problem like this. And providers know very little. Less than 50% of providers know the basic physical activity recommendations from the physical activity guidelines for Americans. Only 16% know that any diet, or know the types of diets that would work for obesity. And that's because there's a lack of education in medical school and residency and in practice. Furthermore, providers are not taught behavior change strategies. And to your point, this whole importance of shared decision making is critical. Whereas the model that providers mostly engage in is, they tell a patient, you've got a weight problem, you need to lose weight, you need to be more active or eat better. Well, patients know that. That's not news. And it's hard for me, tobacco use is a behavioral issue. But I don't think we've had as complicated a problem as obesity, which has so many environmental determinants and behavioral determinants, and the lack of understanding of providers about what is at its root and how to begin to navigate care.
And do you think you solve that at the physician level? Like that
No.
lack of expertise, the lack of time, the lack of reimbursement, to me it always gets back to there have to be other models that are scalable, because that's not.
No,
it's
I completely
docs
agree.
don't have time or expertise, and they're not going to get paid for
they
it.
need to guide
Right.
need to guide therapy, but the therapy has to be delivered by somebody who's trained in behavior
Exactly,
change
yeah.
strategies, and that
answer
could
is-
be anybody.
The answer is yes also, not yes only.
Yeah, true.
I mean, just to get back to what Jim said before about asking the question about this sort of top-down, bottom-up data, I think the answer has to, again, be both. I think that what our cell phones are now enabling us to do in terms of wanting to share data so that, the number of people who do genomic testing and voluntarily share their genome, and I think there's lots of that bottom-up. But at the same time, I think we have to insist that the provider systems and others provide the kind of data that's necessary for accountability. And can that go down, whether it's the clinic level or the provider level? I don't have it up on a slide, but I just pulled it up while we were talking. This is the dashboard that Mexico has now. So the 12,000 clinics that are operated by the Ministry of Health in Mexico, for every one of them, there's a little dashboard like this, which tells you what proportion of their diabetic patients have had a hemoglobin A1C to monitor their control of diabetes, what proportion are under control, what proportion have been tested for hyperlipidemia, just basic indicators. We should have much more in the way of dashboards in this country, and that can only happen if we have legislative, it doesn't have to be national, but it can be state level. We have legislative approaches, but at the same time, we can have what you were saying about having that bottom-up data populate a huge amount. I mean, if I live next to Kaiser, so imagine if Kaiser's 11.5 million patients, what proportion of them would voluntarily be willing to share their medical records in a way to help medical research?
Yep.
The answer is almost all of them, when asked, say yes.
They do.
And that's just fabulous data, because you've got data about their employment, you've got data about their family, you've got data about where they get their care, you've got data about their medical history. I think we are on the cusp of something here, but I think it's going to have to be a combination of that. Some things you're going to be forced to do, because if you're a provider, then there's accountability and disclosure, and some of it's bottom-up enabling.
So we have a lot of that data, but it's de-identified and it goes into the Sentinel system or to the query system. And we have no ability, in some cases, unless the patients consent, to go back to these patients and do anything with this data. So what are we going to do about that? Because to have an intervention, to have the data, and to understand someone is at a higher risk or needs to be screened, or there's a problem with adherence, how are you going to do that when we have hundreds of millions of lives, but often we have no access to that or ability to do anything with that data.
So look one person closer to you over there.
Yeah, but I think that's where we're on the cusp. I honestly think that's where we really are on the cusp, because when you ask people to share their data, right, you have to gain consent, and there's a program in place. It's not just for research, right? But if there's a program in place that helps me manage, my condition, or helps me manage my child's condition, we see just incredible levels of consent.
So if you see that I was a smoker and my mother died of breast cancer at an early age, and you see these patterns, and I'm consented in a program, and I'm 30 pounds overweight,
Right.
you have the ability to call or suggest additional screening or genetic counseling.
Right, to do outreach and offer services, absolutely.
And Frida,
Yeah, I just wanted to do two things, though. One is, I don't want us to forget the yawning gap in knowledge. I mean, just the simple, people don't really necessarily understand their risks. You would think, how can you not understand? But they do. Can you pull up slide number 4 for me? And I just want to, this was a survey that was done by the Cleveland Clinic earlier this year. These are the percentages of Americans that know. I mean, these are all very simple concepts in health, ones that we've been talking about for, 40 or 50 years. But, only 28% of Americans know that people with diabetes die mostly of heart disease. Only 25% know that HDL is a good cholesterol.
Yeah.
And about half know that LDL is a bad one. I mean, these are just gaping holes in knowledge, so that even though we can reach out to them, unless I think we can get our arms around health literacy, distributed across communities, people won't know when you're telling them what to do. So I think it's really, important that we somehow address this. And these are just a few statistics. If we went into some of the others, you'd be downright scared. So I think that's one. And then two is, we've talked a lot about the technology that we have available to us. It's Star Wars stuff, actually. And, I also think we have to be careful because we're delivering, perhaps, Star Wars solutions into the Flintstones healthcare system. And, so we've got all kinds of fancy schmancy stuff, but I'm not sure that we have clinicians who know how to deploy it, systems that are prepared to use it, patients that kind of know how to weigh in on these things. So I think it's not just deploying them, but somehow aligning, educating, transforming the system at the same time.
Yeah, and we can get, I agree, carried away with sort of how we use data and technology. But to your point, health literacy is a huge problem, and it gets to my joke earlier about people that are pre-diabetic and they're good with that. But honestly, so much of what we also have to do is low tech approaches, right? So house calls, right, and with appropriate, providers, not necessarily physicians, but we're using EMTs in communities who they're in the community to go in, and specifically with diabetic populations who, for whatever reason, these tend to be in our Medicaid business, so lower income, people that just don't see a doctor. They don't fill their scripts. They've got social barriers, they have transportation barriers, economic barriers, health barriers, and we're literally using EMTs to go to their home and do environmental scans, and they have license, so they can screen. And then they bring them because they bring them to specialists if they need to go, so really low tech. But I can tell you the reception rate is amazing because these are people in uniform from the community coming to your door. I think we have right now 80% acceptance rate when they get that call to say, can I come visit, do an environmental scan, help you sort of understand how your condition is being managed. And 70+% of those patients then wind up with that EMT going to a specialist. So the system savings are massive. The sort of consumer experience is incredibly positive, and that's low tech, right? That's not technology, that's not data, that's just going to someone's home and helping them manage their condition for a very low cost.
That's a good uplifting thing that's working, sort of point to, I was just starting to feel lost, like we had to take on everything in the world. So there's things like that focus, and they work because of the human element too. Right. I mean, for all the data and technology and lightsabers and stuff that we're going to have, where it's
house calls.
Yeah, house calls.
With coaches?
Yeah, with people who have health literacy above the average of the population, but are not necessarily gone through 40 years of medical school.
Right.
Bill, you had something to say, and then I was hoping we might have a couple minutes for audience questions.
Well,
so
let me
let me
just make a quick point.
Yeah.
We're still, I think we've been very medical centric in this discussion, and a problem like obesity is not going to be solved clinically. We've got to integrate clinical and community services. And to the point about what Kaiser is doing, what I think they need to add to their medical record is a zip code that's tied to resources within the community to which patients can be referred. But this integration is a critical element of the management of all sorts of chronic diseases, because you can't very well change your diet if you're surrounded by liquor stores or convenience stores that don't stock healthier items. You can't very well be physically active if you live in a community that doesn't have access to recreation facilities or is a walkable community or a safe community. So I think that we've got to be much more cognizant of the community element and the environmental element that ties to the management of these chronic diseases.
Yeah, I was going to say something very similar, and I have to credit one of the restaurateur up the street from Berkeley, Alice Waters, who's done a lot of work in school gardens and teaching kids how to cook in schools, because before you need the EMT, you have a huge proportion of people that don't have any idea how to prepare a cheap, fast, nutritious, healthy meal in their home. And so the McDonald's is a cheaper and easier option for them. and unfortunately it's a much less healthy option. So that is also low tech. I mean, that's not lightsaber work, but it does mean understanding what you can do with root vegetables. It means understanding what you can do with foods that you can put in a slow cooker, and how you can manage being a single parent and still prepare food. So there's lots of low tech aspects of this too.
Yeah. Okay. What have we not covered that we really need to hit? All the way in the back. And there is a microphone. Yeah, we can just wait for the mic.
First of all, thank you for the topic. I'm the CEO of a corporate dining company, and my purpose in being here is to talk to this panel. I'm on something called a Google Innovation Lab, and our view is that the best way to attack this is through corporations. And the reason for that is we have employees who happen to be patients, who happen to fit in the obesity crisis, and we're the ones paying a big part of their healthcare costs. So if we can help educate them at work, if we can teach them not to drink sugary drinks, we can start to drive our healthcare costs down. We're giving big reimbursements if they go and get metabolically screened, which I'm sure there's all kinds of controversy. It has a chance to be bipartisan, right? And so my view is that there's some big, heavy-duty corporations that would work together with people like the Milken Institute to go after what we already know to be the solution. Let's quit consuming so much sugar. That's a good start. Let's know our numbers. You just showed a chart that says they don't know their numbers. So I think corporations have a big chance, and then corporations can go out in their communities because the millennials really want to be involved in communities.
And
So
what's your
that's-
question?
That's a little bit of a statement. That's a little bit of a statement, but do you agree, Mr. Dietz, with what I just said? Do you think
Yep.
corporations can play a big role in the solution?
Absolutely. Absolutely.
Good setup.
Worksite interventions are very effective and very cost effective. So I agree completely with you, and would be happy to have a discussion with you after this.
Yeah. Questions other than, do you agree with what I just said?
Thanks for a fascinating discussion about obesity. I wanted to ask about something else, about smoking and tobacco. I mean, I think there's still something like 500,000 people dying from that. Has that, each year, have we stalled out on that? Is there still a way to move those numbers down significantly?
Do you want that? I mean, I can.
I don't know. I mean, and I don't know the numbers as well as I need to in terms of smoking cessation. I know that there's a huge amount of people still smoking, younger people. You travel overseas and you see more and more of it, and particularly among younger people. We're doing better in diagnosing, treating, genomically understanding the nature of the disease, and people, it isn't an automatic death sentence, but the problem is the behavior. For 20 or 30 years, if you're smoking and you give it up at 45 or 50, you've been smoking a pack a day from your 20, you're still at very high risk. The issue is how to get people to stop smoking completely, and that seems to be, first of all, it's addictive. It's weight control for young people. If you go into really interesting environments in New York City with models or actresses, they're all smoking. My son is a film director, and on the set they're still smoking. Why? Because they want, I'm shocked, but they want to keep their weight. Dancers, ballet dancers, so there's still a lot culturally. I think the good news here is we now know who's at risk if we screen them early and we have an intervention. That whether it's removal of a portion of their lung, if it's just screening, we can get them earlier and treat them and they can live longer. We're doing the largest lung cancer trial in the world on the lung map. And it's for people who have genomically testing a trial that's in 700 cities in this country and Canada. And it's, if everyone is tested genetically, so, and for all rare cancers, some whether it's 2%, 5%, 8%, you'd never get to treat these people because it's not one disease. And once you understand who is likely to respond, we can really have better health outcomes for patients. But it still goes, and of course we're seeing a lot of non-smoking cancers too, and that's another issue that we're beginning to put our hands around. But there's a lot we can do.
I think Frida has something on this.
Yeah, I just wanted to add a couple of things. I think we've not quite stalled out as we have gotten to the point where the communities are harder to reach, patients are harder to reach. And there are a few pockets that we're beginning to identify that are at greater risk for smoking for a whole host of reasons. Veterans, for example, is a large over-indexed population. The other population that's really interesting, and there's some recent studies that underscore this, are the mentally ill. So people who have chronic mental illnesses tend to be smokers, tend to die of smoking-related illnesses 25 years younger or 25 years earlier than the general population. And there's a lot of myth, if you would, and misconception about their willingness or desire to stop smoking and their ability to stop smoking. And a number of studies recently have shown this is a population that, for a whole host of reasons, are not even approached about support and smoking cessation, but we have an opportunity to do so. So I think we're beginning to kind of really dig in populations that are having a more challenging time, less availability to the information, less availability to support, et cetera. But we're beginning to push into those communities as well.
But we've been trying to be cultural piranhas with people. It's not fashionable. But the truth of the matter is, in many cultures, it's very fashionable, and it's very important, and it's addictive, and they're a prime. And I don't know the numbers for young people, but I think the American Cancer Society says it's diminishing, but I'm not so sure.
It is going down.
It's going down.
Is it going down?
Right. But, and I was
globally.
trying.
But do we know the subpopulations where it's
No.
not going down?
No, we don't.
See, that's the issue.
And globally, it's not stalled at all.
Correct.
And I think that, although it is interesting, I mean, I was stunned when Mexico City banned smoking in bars and restaurants, and the speed with which that happened after New York. But at the same time, go to Asia, and you see very different patterns. And you see, in the case of China, it's basically a government monopoly that sells tobacco, and there is a potential there to do an awful lot, but it's also a really important source of revenue. So, you have these big problems. Malawi, similarly, huge problem with tobacco production being a major driver of the economy. So you've got different dynamics in different places, but the kind of tobacco being now kind of confined to these special populations that are either hard to reach or at especially high risk and stuff, that's not the case in the developing world.
Okay, someone take us out on a more positive note. And actually, Frida, you said mental health, and then I realized that we'd gone the whole hour talking about chronic disease and not talked about mental health. And that's probably just more due to the scope of the problems we are faced with, but maybe also indicative of some sort of bias. Something that's working in mental health and chronic disease, as a chronic disease, that we could leave here thinking there's some progress being made, there's something good we can do.
Well,
not to put you too much on the spot.
No, I was going to say there's a lot positive, although the progress has been slow over the last 20 years. I think we've really defined biology better than we ever have before. We're not all the way there, but we're improving. And I think on the preventive side, we're beginning. Bill had mentioned earlier some of the ways in which we are now identifying mental illness as a risk factor, or trauma as a risk factor for the development of mental illnesses, and being able to intervene early. And there are a number of programs that have identified risk factors, have put preventive programs in place with children, with victims of abuse, and with others that have really made a difference long term. Scalability is an opportunity for us, but we do know some programs that are working and they're being translated. And hopefully, if we're here next year, we'll have an opportunity to talk about some of the ways in which we're making progress in this space.
Let's do it again next year. Thank you to all the panelists. Thank you for coming.